All right. So today's presentation is measles more than a rash. Funding for this presentation was provided by the Kentucky Department for Public Health. There are no discussion around any particular products, and they have no financial interest or other relationships with manufacturers of products, and no commercial support was provided for this educational activity. So our objectives for today are to describe the measles virus transmission and to be able to articulate infection prevention measures for the measles virus. So historical measles, um, I'm gonna So historical measles in the 9th century, Persian doctor published about measles. This was a writing that was actually a comparison of measles and smallpox, where the physician noted that these two diseases were in fact not the same. In 1757, there was a Scottish physician who showed measles virus was actually caused by an infectious agent. And in 1912, measles became a notifiable illness. And public health officials started to track this particular viral infection. In 1954, measles was isolated in the blood. And in 1963, a vaccine was established. This vaccine was improved in 1968, resulting in measles being declared eliminated in the United States in 2000. So when we look at global measles, you can see that it is prevalent around in many, many different places. You can see here that transmission is occurring everywhere from Somalia to the United Kingdom. And like I said, you'll look over and the United States is white, right? There are, in 2000, measles was declared eliminated in the United States. While there have been some small outbreaks or international cases, there has not been widespread transmission. However, we know that individuals travel internationally all the time. And if proper prevention measures are not taken, there is a risk of spread throughout the United States. So, what is measles? Measles is caused by the morbillivirus. It's an enveloped negative sense RNA virus. It only infects humans as the natural host, but it has an attack rate that is incredibly high. About 90% of susceptible hosts in close settings will become or can become infected with measles. It's spread through direct contact with droplets, and it is an airborne illness. Incubation is 11 to 12 days for that period of exposure to prodromal symptoms, and then the interval of about 7 to 21 days from exposure to when the individual develops the telltale rash. There is a vaccine available that is highly effective for measles that we'll talk about in just a minute. So this slide here, I think, just shows a very nice depiction of the incubation and infectious period. You can see there that the red 0 there is the date of rash onset. So an individual, you would go back about 4 days to say this is when they were probably starting to be infectious. The days of rash, minus 4 days and plus 4 days is that infectious period. And the date of rash to up to 18 to 21 days is that time frame where they could have been incubating the disease. So what are the symptoms? So the symptoms are pretty similar, at least in the prodrome phase, to many other illnesses that individuals may get, particularly during the respiratory season that occurs. So fever, malaise, cough, coryza, and conjunctivitis, those 3 C's. Individuals may develop Koplik spots. So those are the white spots on the mucosa of the mouth. They usually appear about 2 to 3 days after symptoms begin. If you see complex spots, then you should suspect measles for sure. If you don't see complex spots, that does not mean that the individual doesn't have measles. So it's highly characteristic of the disease, but they don't always appear. Then you develop the maculopapular rash. This rash usually appears 14 days after the exposure, and individuals are considered contagious from 4 days prior to 4 days after their rash appears. So during that time frame where there's no rash and they have these prodromal symptoms is when many times those exposures to other people's appear because you don't have those classic measles type symptoms potentially. Treatment is supportive, as well as a recommendation for vitamin A. There are specific dosing recommendations that are provided by the American Academy of Pediatrics. These are provided once daily for 2 days. It's immediately on diagnosis and repeated the next day. This is recommended due to the impact that vitamin A has on the immune system. And while children in the United States are probably not vitamin A deficient, there is evidence that suggests that they are if they have measles. So is measles just a rash? The answer to that would be no, right? So other complications include ear infections or otitis media. About 5% of individuals will develop a pneumonia, croup, diarrhea. Encephalitis, acute encephalitis occurs in 1 out of every 1,000 cases. Immune amnesia, which this is after infection with the measles virus. The immune system has a very high rate of measles virus lymphocytes or memory cells. Unfortunately, this high rate of measles specific memory cells replaces other memory cells, leading to a decreased ability for the body's immune system to respond to pathogens they have been exposed to in the past and should be immune to. So they're highly susceptible to other opportunistic infections. So you might have a great immunity to measles, you're not really doing so hot against other opportunistic infections that you should otherwise have immunity to. Death is about 1 to 3 per 1,000 cases, and about 20% of individuals are hospitalized. So as it relates to testing, so according to the Kentucky Health Alert that was sent out on February the 27th, RNA by real-time PCR and a respiratory specimen, throat or nasal pharyngeal is the preferred testing for measles. And clinical specimens for the RT-PCR and the virus isolation should be collected at the same time if serologic testing is being done. Detection is most successful when samples are collected on that first day of rash through the 3 days following rash onset, but maybe as successful as late as 10 to 14 days post-rash. You're encouraged to contact the local health department or the Kentucky Department for Public Health to submit specimens to the lab for testing. Serologic testing of measles IgM antibody is available at many commercial labs and is also an acceptable mode, but the turnaround times for results may be delayed, which can cause a number of problems. And so really the recommendation is that real-time PCR testing. Of course, healthcare providers should report at any time that they suspect measles, and testing is warranted. So what is measles immunity? So there's a couple of things that would say that an individual is, in fact, immune to measles. This includes proof of adequate vaccination for measles, mumps, and rubella. And when I say adequate, it means that you're in line with whatever those recommendations are for childhood vaccines, and then the appropriate full dosing for anybody who has passed that time frame. Laboratory evidence of immunity, so making sure that you have antibody, laboratory confirmation of the disease, and then birth for people that were born before 1957. I will point out that in a healthcare setting, even though birth before 1957 is considered acceptable evidence of immunity, healthcare personnel and healthcare facilities really should consider vaccinating healthcare personnel born before 1957 if they lack that lab evidence or confirmation of disease. Additionally, proof needs to be more than verbal. So saying, well, I remember when I had measles doesn't count. So you really either need to have proof of immunization through records or proof through lab confirmation in some way. So I put this slide in here just because I think it points out exactly how effective the measles vaccine really is. So you can see here that the vaccine was licensed in 1963, and you can see the exponential decline of measles virus disease over time. That second dose was recommended in 1989, and you can see that after that second dose recommendation, the number of cases dropped off significantly. So prior to that, there were a couple of blips where you can see that there were some outbreaks potentially related to either waning immunity or just not enough. In 2000, you can see there that we were declared as eliminated. And this is defined as the absence of endemic measles transmission in a region for greater than 12 months and the presence of well-performing surveillance systems. So there are two different vaccines. So there's the MMR, that is a combination of the measles, mumps, and rubella vaccine. Within this, there are two vaccines that are available in the United States. They're similar in recommendation, and they are also considered interchangeable. And then there is the MMRV, which also includes the varicella vaccine and is licensed for individuals 12 months to 12 years of age. Most people vaccinated with the MMR or the MMRV will be immune to measles for life. Review of findings from both post-licensure studies supported the conclusion that children who receive the MMRV vaccine when they are 12 to 23 years or 23 months of age are about twice as likely to have febrile seizures during the 5 to 12 days following vaccination. And so it is recommended that children on that first vaccine receive the MMR unless the family or conversation with the provider suggests that they want to, in fact, have that MMRV because they would actually get an additional shot. But the risk for febrile seizures, usually the patient or the child will get an MMR, that first one, and then get MMRV on that subsequent vaccine. I have these here, not big, these are the viz sheets. This is the MMR viz sheet, and I suspect that you won't be able to read these exactly perfectly, but I point this one out and you'll have the MMRV viz sheet to see as well, just because they've got an exorbitant amount of information related to the vaccine. What are the risk of the vaccine? What is serious reactions? Why the person would want to get vaccinated. So these are really great teaching tools, and what should really be provided to, well, are required to be provided to family and the patient when receiving a vaccine, but they really do have a lot of great information that can be used when having conversation with patients and caregivers about whether or not they themselves or their children should be vaccinated. So here's the MMR, and then here is the MMRV vaccine viz sheet, which speaks to the risk for febrile seizures in that young age group. So this here just shows when individuals should receive that MMR vaccine. The first dose of the vaccine is administered at age 12 to 47 months. Again, you can use either one, but providers typically do the MMR. For the second dose, this is at any age. The use of the MMRV vaccine is generally preferred. The likelihood of those febrile seizures goes down, particularly at the age of 4 to 6. And so this one, you would get less shots and the risk for febrile seizures is down, so it's the preferred choice. Infants that are ages 6 to 11 months should get one dose of MMR vaccine if they're traveling internationally or in an outbreak setting. This does not start their vaccine series, though, so they should get 2 more vaccines after their first birthday, the one that they would get at 12 months, and then the one that they would get at 4 to 6 years of age. And adults should be fully vaccinated or immune before traveling as well. So measles vaccine coverage in the United States, like I said, the measles vaccine is highly effective, and really does prevent transmission of disease. And so it's very important to know what is the vaccine coverage in the United States. So it's widely acknowledged to have a herd immunity. You'd want to have about 95% of the population immunized. So you can look at this map here of the United States and see that there are some states that have greater than or equal to 95% vaccination rate, but it's not very many, about, I don't know, 8 or 9 states there. And so why is this important? So during the 23-24 school year, vaccine coverage among kindergartners in the United States decreased for all reported vaccines from the year prior. Additionally, this does not include children who are homeschooled or may not go to a traditional school where proof of vaccine is required, and therefore it's not included in these numbers. So the numbers could be more or less. And so when you look at the states here, West Virginia reported a 98.4% vaccination rate amongst their kindergarten children in 2023-2024. Idaho, however, was as low as 79.5%. So we've got one state that's doing very well and one state that maybe has some opportunity. As it relates to the state of Kentucky, we were at 90% is what we reported for 23-24 school year amongst kindergarten age children. And so obviously that is less than the desired percent, which is about 95. So what about measles cases in the United States in 2025? This map shows prelim cases for 25. This was updated on March the 6th. And so we know that there is an outbreak occurring in Texas. So this was identified in late January. The Texas Department of State Health Services reported an outbreak that started in Gaines County and has grown to include the Southern Plains. As of March 11th, they had identified 223 cases. 29 of those patients had been hospitalized and they had 1 reported death. New Mexico's State Health Department is also reporting an outbreak of measles. This is in Lea County, which is a county that neighbors Gaines County. As of March 11th, they have identified 33 cases, including 1 case in Eddy County, which is a county that is this is the first case that they have identified outside of Lea County. New Mexico is also reporting that they have 1 death under review. Then on March 11th, so just yesterday, Oklahoma reported that they had 2 probable cases of measles that were thought to be associated with the outbreak that's currently occurring in Texas. From the report that I saw, the individual self-isolated after they realized that they may have been exposed. So hopefully that will not continue to spread throughout Oklahoma, and that will be their only 2 cases. But you'll see there that obviously it is impacting the neighboring states of Texas. And so when you look at the immunization rates within these locations, Texas has an immunization rate of about 94.3%, New Mexico 95%, and Oklahoma 88.3%. The majority of the cases with this particular outbreak were individuals that are not vaccinated or not fully vaccinated. And this outbreak was thought to have started in a community with traditionally low vaccination rates. And so I point this out because Texas, like I said, has a relatively high vaccination rate, 94.3%. But the community that was impacted may have had a vaccination rate that was much lower than that. There was one case that was identified in Kentucky. This was a single case identified in February and was thought to be associated with international travel. And to date, no additional cases have been identified. It's also important to note that the total number of cases in 2024 for measles, as per the CDC, was 285. We are at 222 cases already this year of measles. There have been multiple health alerts that have gone out. So there was one in the state that came out for Kentucky excuse me, February 27th, with a number of recommendations, as well as a recent one that came out from the CDC on the 7th of March. What was interesting about this one was that it stated that the Texas Department of Public Health has issued recommendations for affected counties in Texas, including to have infants 6 to 11 months should receive an early dose of MMR, and then subsequent doses should follow the CDC recommendations. So what do we do about infection prevention? And this is really a very important piece as it relates to preventing the spread to other individuals. So we want to have rapid identification and triage. The virus is able to stay suspended in the air for up to 2 hours. And this might be dependent on air exchanges within the space, but even still, 2 hours is essentially the gold standard of how long you would say this area, it could be a space that is concerning for subsequent transmission, even after that individual has left the space. Immediate isolation is needed, so placing the patient in a negative pressure room and ensuring that staff wear all the correct personal protective equipment. This includes wearing an N95 mask or a respirator, even in the setting of immunization. You want to close the location that the individual was in. It's recommended to close the exam room for 2 hours after the infected person leaves that space. Again, this is because the virus is thought to stay suspended in the air for that period of time. And so other individuals that come into that airspace that are susceptible may become infected. You also want to identify areas during the time period the patient was in the facility and 2 hours after they left. Because you may, especially if the measles case is confirmed, you're going to have to figure out whether or not those individuals had immunity or are potentially exposed. Post-exposure prophylaxis, and we'll talk about that in a minute, is available. And then key piece is immediate notification of infection prevention, public health, epidemiology, and other key stakeholders to really develop that plan of what you're going to do, how you're going to test, what is going to be your exposure definition, and how far out are you going to go. I suspect this is not something that everyone can read very well, but I just wanted to put this in here so that you knew that it existed. The American Academy of Pediatrics Red Book is where this information comes from, and it outlines who should get post-exposure prophylaxis and what should that look like. And this is outside of the administration of the MMR vaccine. So what I wanted to do next is really just kind of go through some scenarios. So if you can just put what you think in the chat to just see where are we going? What do we do? So we have a patient who's 13 years. The individual presents to the provider office and states with cough, conjunctivitis, and fever for 3 days. They sign in and wait in the waiting room for 10 minutes before being roomed. And in the room, it is noted that they have Koplik spots. What do you do? Yes, Nita said big trouble. Yes, potentially. So in this particular setting, you would really have to think about Implementing airborne precautions as soon as possible. The patient was in the room for the waiting room for 10 minutes. And so it says it's not entirely clear how long is a short period of time. Is that 5 minutes? Is that 10 minutes? To say that the waiting room has been exposed. And so you would really have to understand what's that going to look like for your facility. If it's 5 minutes, which is, what some institutions use, that waiting room needs to be closed down potentially for 2 hours, right? And how do you operationalize that for the individuals that are in their current state and subsequent patients that are be coming into that space? Is there another space that you can use? What's that going to look like for flow through the office? Okay. In this scenario, so we have a patient who is 7 months, presents to the ER with cough, runny nose, and rash. Family states that they had recent international travel and the patient is immediately placed in a negative pressure room. Upon further assessment, the patient traveled with their family, including two other siblings, none of which are fully immunized. What do you do in this scenario? Any thoughts? So I think in this particular scenario, the individual was immediately placed in a negative pressure room. Travel history was completed immediately. So the room that they go to would likely have to be closed down for a period of time. But it seems less likely that the waiting room would be exposed. But clear conversation with the health department is obviously going to be needed to, again, help to determine what is going to be your case definition, what are you going to consider to be exposure, and what about exposure throughout with the other children who are not fully immunized and anybody else in the public. And then really quickly, we will just go through one more scenario, the scenario where the patient, in fact, waits in the waiting room before being roomed in a regular room, in which case, what do you do with the ER proper? What do you do with the waiting room in general? And so I bring up these scenarios because, again, symptoms seem pretty common for many childhood illnesses, right? And so having a process that you've actually worked through to say, okay, how are we going to operationalize closing down this space or closing down this room or determining who is a close contact or who is potentially exposed, and then working through those processes beyond just what is written down on your paper as a piece of your plan, I think is going to be very helpful in preventing potential chaos should someone come to the emergency department and you have to figure it out immediately in real time. So in conclusion, measles is clearly more than a rash. The vaccine is available and it's highly effective. It is important to do that thorough assessment of patients to really understand where have they been, have they been exposed to anybody that has had measles, is suspected to have measles. Did they go and travel internationally or to a place that is experiencing an outbreak? Isolating individuals promptly to decrease that risk of exposure, and being sure to reach out to infection prevention, EPI, and public health if there are any questions or concerns. And here are my references. And feel free to follow us on social. And Kirsten put in to the chat the link for other future grand rounds.
Awesome. Thank you, Julia. That was a great presentation and very timely. Does anyone have any questions for Julia?
I have a quick one.
Sure.
So, Julia, you had mentioned either yesterday or maybe today, the first vaccine. So if you were born in, say, 1963, around that area, there is some question that the first vaccine then was not as good as the one that came out, I don't know, around 69. Can you elaborate? Because I happen to fit in that group. Is it recommended that we just stick to the titers for those people who were in that small period of time?
That's a good question. I know that typically for healthcare workers, at least they can do titers, but I think that's a good question to, follow up with your provider about to see do you get an additional dose or do you check titers and then see where you are from there? So I think that that's a conversation that you would have with your provider to see what is the best choice for you clinically.
Great, thank you.
Thank
Does
you.
anyone else have any other questions? All right. Well, feel free to hop back on for our next session. I've added that link in the chat, and we'll see everyone next time. Thank you.